Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back. This is Adam Rosen, and you're listening to the Total Knee Tips and Pearls podcast. So today what I'd like to do is talk to you about balancing. And balancing is a huge topic. I mean, this is a topic that we could talk about for hours and hours and hours and still not have a complete understanding. And I truly believe that it is one of those things that you can read and listen and ask a lot of questions, and you're really not going to fully understand it until you have lots of practice and feel lots of knees. And that's where it comes into handy in the office of, feeling every normal knee, every arthritic knee. You'll notice the difference in the nuances in laxity throughout the range of motion, but more importantly, examine every total knee. So even if you're seeing somebody for right knee arthritis and they've had a left knee done somewhere else years ago, examine that knee and try to get a good assessment of what knees feel like and what the patient feels as far as do they like it or not like it. And what you'll tend to see is there's a lot of knees that are tight and a lot of knees that are loose, and a lot of patients love them. And on the flip side, you're going to see some patients that have painful knees that balancing wise in your hands feel great. So it's a really difficult thing. And this is truly, I believe, more of the art than the science of knee replacement. And that art of medicine comes into knowing the patients. And the unknown for us is the biology. We know what's going to happen in the postoperative period with that patient. So as far as balancing, so we're at a point now where we have, done the total knee replacement, and now our trial implants are in there. So the first thing that I do is once my trials are in there, is I just lift the leg up and I get a feel right away of, does this knee drop into extension? Does it go into hyperextension? Does it still feel like I have a flexion contracture? Sometimes you can visualize it, but sometimes we're talking a couple degrees, and especially if someone's obese, it's really hard to see, are they going into recurvatum or not? But that's the first thing you get as a feel is just when you pick it up, does it really drop into extension? And then I'll just flex and extend the knee just a few times and get a feel in my hand. Does it feel like it's gliding normally? Is there a weird pivot? Is anything snapping, catching? Do they go into flexion or does it stop? Is the PCL really tight? Or if I have a PS design, is the tibia poly lifting off, or I'm just not getting into flexion? What does my tracking look like? So you can really, in 30 seconds, just lifting the leg up, bending and straightening the knee a few times, get a good feel of, am I balanced or at least in the ballpark? And at that point, then I'll go through actually doing my varus valgus stress testing at both full extension and around 15, 20 degrees of flexion. And I make a real effort in the operating room to talk to people and tell people, because sometimes you'll have a knee that drops into hyperextension and you have posterocapsular tightness. And if you check them in varus valgus, you might get fooled into believing that they're actually quite stable. And then as you bring them not even all the way down into midflexion, but just 10, 15 degrees, and then you check them again, there's a huge amount of medial-lateral laxity. So that's probably someone that is tight in full extension because they're actually in hyperextension. But if you pick a knee up, drops into hyperextension, you don't even waste time doing all your varus valgus because you're going to be 2-3 millimeters off. You're not going to get any real good assessment of medially, laterally, what is the balance point? Am I tighter on one side than the other? I think it is important once or twice to flex it, because if you go into recurvatum and you're loose medial laterally, but you can't even get into flexion, you're going to be jumping ahead to the other steps of what's my issue? Why am I so tight in flexion and loose in extension? But if you're otherwise really, really loose, you pick it up, it's hyperextension, varus valgus, just go up a poly size or two before you start going through your algorithm of varus valgus, mid-flexion, and deep flexion. So if you like that poly thickness, whatever poly you've put in there, and you feel that you're pretty well balanced in flexion and extension, now we're going to do a deeper dive. So this is where you really check your varus valgus. You want to stress them at full extension. And again, if you're unsure, just flex them a little bit more and make sure that you don't gap significantly 2 millimeters more, because again, then you're probably in hyperextension. But then also you want to check them in their flexion position too. So I'll check flexion, and I'm not a believer in the, take the foot, bend the knee to 90, and then pivot the hip internally, externally, rotate it to check my flexion varus valgus. I don't believe you get a good assessment because you're compressing the knee joint. So if I'm checking my varus valgus in flexion, I have a tendency to put my hand, or if it's a really large leg, I'll have my assistant grab underneath the thigh and I'll pull the ankle down and I'll then varus valgus it. And I can get a good assessment there of what my laxity is like. This is similar or analogous to if you're examining someone in the office and you have them on the exam table and you lift the table up while their legs are dangling. You have the use of gravity, and you can get a better assessment of your varus valgus stability in that flexion position. So I believe that that's a better way of testing than just trying to pivot. I think if you're really loose and you're pushing up, you might notice some liftoff medially or laterally, but you're not going to significantly see those subtle changes that I think you get better when you try to distract the joint in that position. So the next thing that I'm also doing is then checking my anterior posterior. Now that feel is going to be different based on, do you like a tight knee? Do you like a loose knee? And if you have a PS, are you stopping on the post? If you have a cruciate retaining design, do you have appropriate tension and rollback of the cruciate and of the femur, and making sure that you're balanced through that range of motion. As long as you're balanced, then we're good. But if you're not balanced, this is where you need to figure out why and where. And I'm sure that most people in training have had that point where you've done your knee, you've picked it up, and the staff member says, "So what do you think?" "Oh, yeah, I think it's really good." And then they pick it up and they feel it and they go, "No," and they put another poly in, or they release a little here or there, and they go, "Now feel it." And you feel it again. "Oh, it's better." So you really want to kind of get that feel, and that only comes with repetition. But you want to really have a good understanding of, okay, why did they do what they did? Or what did they feel that made them do that one thing? And I believe that that will help you start to put those things into your brain as to what things do I look for every single time. Or if I feel this one thing 2, 3, 4 times, and when I did this, it made it better, and when I did this, it didn't. It helps you create that algorithm in your head of what to look for in the future. But the other important thing, and if you ask 100 surgeons, you get 110 different answers of, what is the surgeon looking for? Because I know in our programs, you have a attending A and attending B both use the same implant. And attending A likes his knees in tight, and attending B likes it loose. So you go from room to room, and even though it's the same implant, you keep misjudging of, do I want to make this tighter or looser? Because each surgeon has its own preference. Again, this is the art of the medicine, not necessarily the science. And what I even find is you get some surgeons that, are tight for a while, and they put all their knees in pretty tight. But then over a period of months, they start to see a few knees that come back a little tighter than they would like. And then all of a sudden they become a little bit of a loose surgeon, and they start to leave their knees a little bit looser, now that we have 1 millimeter polys, until they start having some instability things and they go back the other way. Because the harder part or aspect of all of that is we don't understand patients' biology. How do you know whether or not the patient on your operating room table is going to be one to lay down scar tissue or one that's going to loosen up? Sometimes you can pick and choose. This is a person that's had a prior knee on the other side and a manipulation, and they had arthrofibrosis in their shoulder. More than likely, this person's getting tight. Or you have, a little old lady that's got Ehlers-Danlos syndrome or rheumatoid, and she's just loosey-goosey everywhere. She's probably one that's going to stretch out. But the harder thing to pick out are these patients that you just don't know. And that's the biology that we'll not be able to figure out at this point until we have more information. But the other thing you have to look for is, do you like balancing? There's devices, the OrthoSensor, which gives you this really interesting information about pressure points. And there's another device which is similar on the market, which can give you different points of information and pressure throughout the range of motion. Great information and data. But again, we don't always know exactly for every individual where those pressure points should be to be maximally beneficial for the best outcome. And each surgeon is different. Me, I do have a tendency. I like my medial side to be extremely tight. I don't like laxity on that side, but I always want my lateral side to be a little bit looser. I believe that restores more normal motion in my patients, in my hands, with what I do and the implants that I use. But you may meet surgeons that like it looser here or tighter there or balanced, medial laterally. So you have to, with practice, determine which things you're looking for and how you want your patients to leave the operating room. And it truly is sort of a Goldilocks and the three bears. And I have people do this in hips and in knees, and especially when you're learning, is that if you're doing a hip and you have a zero ball on and you're pretty sure that that's what it's going to be, is, just before you leave and open up the real deal, just try the minus and try the plus. Confer in your mind and in your hands that minus is loose and unstable, and that plus is too tight and too long. And the same thing in the knee. Now that we have 1 millimeter polys, if you do have the option, slip a 1 millimeter smaller. Oh, yeah, that's too loose. Okay, put 1 millimeter thicker. Oh, yeah, that's too tight. The only asterisk caveat there is if you have soft bone. And let's say you have a 10 in and you have a 9 and 11 available. You have a 10 and you think the 10's great. You try the 9 just to confirm, oh, yeah, it is really loose. And you put the 11 in. If you put the 11 in a very osteoporotic patient and put them into full extension and deep flexion, you may compress the tibia, especially the tibia, onto that soft cancellous bone. And now you've confirmed, oh, yeah, it's a 10. You open up the 10, you put the 10 in, and now at the end of the case, you're loose. So just know that if you have soft bone, that may not be the patient that you want to play around with that up one, down one. But it's something to keep in mind, again, to teach you, your brain, your hands, what is too tight and what is too loose. So I'm not going to go into a ton of detail of that entire chart that your first-year resident should have memorized at this point. Okay, so extension gap, flexion gap, great. We're equal, perfect, you're good. They're both loose, then you have to go up poly size. They're both too tight, you got to usually cut more tibia. But I'm going to go into a little bit more detail on the other four main options. So if we believe our extension gap is perfect, that's really, really good. But our flexion gap is tight. You have a couple of options, and most of these I think people will know of. There may be one or two that you didn't think of before, so that's why I want to bring this up. So if you're doing a cruciate retaining design and your flexion gap is tight, one of the first things that you can do is assess your PCL. And again, I've talked about this before, is if you're doing a cruciate retaining design, you got to make sure that you didn't leave an osteophyte in the notch behind the PCL, which is tenting it. So if that's still there, one, you forgot it. Two, remove it, and that might balance your knee. The other option is you can recess your PCL. I've always been more of a believer on recessing it off of the tibia, larger, broader expansion than the femur, but you can take it off of either. The other option, if you're really tight, you want to release it a little bit, you can actually, I believe it was Merrill Ritter first described this, but I'm not 100% sure. But I want to give credit to where credit is due. But you can actually take an osteotoma rupture and take off a little bit of bone so the PCL can lay flatter on the tibia. It's another option if you want to retain the cruciate. The other option that some people have used too is pie cresting, especially if there's one particular tight band medially or laterally. You can take an 18-gauge needle and just kind of puncture it a couple times, range it through the range, and that might help. So the other option, and we've talked about this before also, is slope. Okay, what was the patient's preoperative slope? What did you cut it at? What does the implant manufacturer recommend? Is the slope built into the poly or not? So you have to look at all of those things and decide, okay, if I cut another degree or two of posterior slope, does that increase my flexion gap? So the other option, if they're really tight, and this comes more into the soft tissue side of things when we talk about that later, but are they a little tight? Or are they a lot tight? So if they're, really tight, we're talking, feels 2-3 millimeters tight. The option is you can resect the PCL, and some people will just put in a dished posterior sacrificing design. Other people will go to PS. So that is an option. If you're really tight, is you can just release and take out the PCL, convert to a posterior stabilized design. And then the other option is, check your medial lateral. If you're really tight in flexion and medial laterally, you look a little wide, you probably have too big of a femur. So at this point, then you can then downsize your femur. And again, you need to know your implant company. And if you downsize, are you increasing your flexion gap by 2 millimeters, 1.5 millimeters, 5 millimeters? So you want to have an idea as to what number you're looking for, but that becomes an option. Okay. Next step, your extension's still really, really good, but your flexion gap is loose. Okay, you got to figure out, well, why? What did I do? So you can put a thicker poly in to balance your flexion gap, but that now is going to make your extension gap, which was okay, now too tight. So you may have to go back and cut more distal femur to put a thicker poly in to balance the flexion gap with the femur that you have on there, and that should balance everything. The other option, if you had the option, and this might be more commonly seen in a revision setting though, where you put your knee in an extension, feels really good, you're still loose in flexion, is you have the option then of increasing your femoral size, but this requires typically a stem and augments. So it's a different animal, but it is something to be aware of, that if you had a significant issue, that hopefully you have those implants available that you can upsize, augment, and stem your femur to stabilize the femur that way. Now, the next option also is you can actually cut less slope if you put in a thicker poly. So if you assess your slope and for whatever reason you cut a lot of slope, and that was the reason why your flexion gap felt so loose, and one of the options is you can cut less slope. And you can do this with a guide, or if you're technically skilled enough, you can do it freehand. So the idea would be, looking at it from the side, you're cutting more slope, but you want the saw blade to exit in the back, so you're not taking any more posterior tibia off. So the contact points in the front of the tibia now are less. So by increasing your poly thickness, you should still be pretty well balanced in extension, and that increased poly thickness is going to balance your flexion gap. Okay, so let's move on now. Your flexion gap is okay, and the two options then are your extension's tight or loose. So if your flexion gap is okay and your extension is too tight, and again, we talked about this earlier on, do they have a preoperative flexion contracture? Did you take two more? Did you release the capsule? So for me, again, I don't always release the capsule from the get-go, but this is the first thing in my thinking, is that if I'm a little tight in extension, I want to go in and strip my capsule and see if that alone will balance my extension and flexion gap. Okay, did, perfect, move on. If not, and again, this comes down to, is it a little tight? You can do a little soft tissue stripping. Is it a lot tight? Then you're probably gonna have to take more bone. So then I'll take two more off the distal femur. The other option, again, like we talked about before, sometimes if it's a little tight, is again cutting less slope. So if you put this knee in there and you're assessing and you're on the upper ranges of slope, then the option sometimes is cutting a little less tibial slope. Again, with the saw exiting in the back, not taking any posterior tibia, but just taking a little bit off the front, you then increase that, half a millimeter. We're chasing 3/4 of a millimeter of tightness and extension to balance the knee well. Now, what about flexion's okay, but extension were loose? So again, your extension is loose, you can increase your poly thickness, but that's going to make your flexion gap tight. So now we kind of go back to the other algorithm of, you can recess the PCL. If there's a big mismatch, by increasing the poly, you've balanced your extension gap. You might have to, go PS. You can alter your slope again, all those things we talked about in the previous algorithm where, now the flexion gap was too tight, but you've had to increase the poly thickness to balance your extension gap. Other option is you could augment the distal femur, bringing the joint line down. And again, this is that choose your own adventure book. So why is your extension gap loose? Was this someone that had recurvatum and you cut a standard distal cut? Maybe you should have cut two less. Or is this someone that had a little flexion contracture, so you took two more on purpose, and now you're kicking yourself because, now that you've removed these osteophytes, they balance well. You could have just taken this standard cut. So not only is this going forward, but every time that you do these, you really want to think back as to what did I do previously that resulted in this outcome? And it may teach you some things to look for in the future to prevent making those steps early. Again, I'm a big believer in, instead of rushing, I would rather in the operating room go back and take 2 more millimeters of bone if needed than to cut a lot all the time and then potentially have lost bone or playing chase because you've resected more bone than you needed to, even if it means a little bit more time to make an extra cut. So the other important thing to talk about is mid-flexion. And mid-flexion is a really hard thing to kind of chase because there's lots of variables there. What type of implant are you using? Some of the older implants used to always have a lot of mid-flexion instability. or are using a single radius type curvature design. A lot of the newer implants have less issues with midflexion instability. But if you flex or extend your femur when you are making your cuts, that can sometimes affect it. As the joint line been altered, that can affect it. So you just want to be aware and then try to figure out which thing is causing that midflexion instability and can you address it. Now, if they're loose globally, I mean, these are ones that they just have super lax tissue everywhere. You're just chasing, yourself all the time, increasing poly, going up 1, 2, 3, 4 millimeters. You got to start thinking, do I need a constrained device? And hopefully you saw this patient preoperatively and noticed that they had a lot of laxity and you've had that called for. But again, those are the things to really think about as far as going through all the different kind of scenarios and algorithms, but not only what are those different steps, but again, trying to think back of how did I get here? What did I do? If I could go back 30 minutes, could I have done something differently at the beginning of the case that would have balanced it better? But I'm always more of a soft tissue releaser first before you start chasing more bone cuts. Now, going into the tissue, and again, balancing is a long topic. I mean, we could have a whole discussion just in the bone cuts, a whole discussion just in the tissue. But this, I'm hopefully planting some seeds and things to look for, and things that you can kind of keep an eye on going forward. So I'm a believer in I tend to release what is tight. You'll read through some old articles and books and some journals that will describe the sequential release. And, one example is if you have a really tight valgus knee and you're going through this sequential sort of release, popliteus, and release here and release there. And then, lastly, you release the lateral collateral. If that was the last structure and you've released every other structure, now the knee's really loose. So you have to have a judgment and an assessment of, okay, I'm tight in, varus or valgus, and these are the structures that are available, and I need X millimeters of room. What things can I release to get me there? Because sometimes I'll have a bad valgus knee where I might release the lateral collateral, leaving the IT band and popliteus, so I have some restraint there, and vice versa. I'm not a believer medially in doing a big release from the get-go. And again, because I try to maintain the soft tissue. So if we're going medially, I'll always, for a varus knee, release my superficial MCL, look for my osteophytes, come around the back corner. And then if I'm still tight medially at the end, then I'm, again, looking to see, can I release my deep MCL? The other option available to you is, is there any more bone remaining? So sometimes you have to go dig in, especially posteriorly, and look, is there any bone that's hanging that you can remove? Can you downsize the tibia? Go down a size, shift it, and do a resection of the medial bone. Another trick. But I'm not a huge fan in patients where they have laxity there and doing an advancement. Some people do that. I haven't been a fan of that. And I typically would just chase that more with going up poly sizes and going constrained before I do a big advancement. More commonly, I think you're going to deal with the tight medial structures from a varus knee, and you can release those. And then, look at your hamstrings and pes and go down and release those. But I think that's probably an easier algorithm for most people. They've seen it more commonly, and you're just stripping and stripping. You just have to make sure that you don't get into a place where you need to constrain. I think the bigger issue then is laterally. So, you always want to be aware of the popliteus and try not to cut it early on, but it's one of those small things that if needed, you can always release it if you need a little release there. If you're over there laterally, one of the important tricks in addition to coming off of Gertie's and releasing your IT band, if you're releasing your lateral collateral, I typically will start to peel it off the femur first, a little bit at a time. You can, if you have a particular band, you can just kind of pie crust that band. You can do a full, release if needed, but again, you need to have constrained. But the one thing that I want to throw out there, which I see a lot of people kind of miss, is that if you have a valgus knee, they have some osteophyte, and you've done a median parapatellar arthrotomy, there's some benefit sometimes to doing a lateral parapatellar arthrotomy. But if you're medial, what you want to do is take out all your implants. You can stick a Homan or similar retractor anterolaterally. You can internally rotate the tibia and valgus and have your assistant help in that position. And a lot of times what you'll find is if you release the lateral structures off the anterolateral margin of the tibia, you'll find some osteophytes. And I find that this is a region where you can get some osteophytes which tent your lateral structure. So without further soft tissue release, you can actually tease these osteophytes off. And then what you'll find is that, wow, now I'm more balanced. So always go looking for the osteophytes. Now, along that line, the other spot which I see people leave osteophytes and not recognize it is along the femur. So this is something during my steps. We go through it every single time, every case. But most importantly in valgus knees laterally is that when you have that femur exposed is take the bovie and come over the edge of the bone and really bovie down to the bone. And more often than not, I find that people are very surprised at how deep that bovie goes. And what they believed was the lateral edge of the femur is actually overhanging osteophyte. And if you take a rongeur and you start to peel this off superiorly, distally, posteriorly, what you'll find is all of a sudden the femur looks like every other femur that you've seen, and it has the normal contour, the normal look. And what you were really looking at before was osteophyte that was hidden that you didn't recognize. And it tightened up all your lateral structures. And then now all of a sudden, without doing big releases laterally, your knee is well balanced. So that's a really, really important thing. Now, last couple things that I'm going to talk to you about, and this is what I'm going to throw out there, and it's something I've been looking at that we're working on doing a study on, so let me know if you beat me to it. But I look at what's called the combined version. So what this is the face of the distal femur. So when you're opening up a knee, try to look at the face of the distal femur and look with regards to its parallelism to the anterior aspect of the tibia. And what you'll start to notice is that in some knees, the tibia appears to be externally rotated to the face of the femur. Sometimes it's parallel and sometimes it's internally rotated. But it's important to look at that early on, because what you may find is then at the end of the case, especially if your tracking is off, that plane has now changed. So when you look and it looks parallel, that's good. What I find is a lot of times when you have issues with tracking, you're looking at that and you don't look at it with other knees, or you don't look at it beforehand. So you don't know where the person started. So I'm always looking at the face of the femur to the anterior border of the tibia. I'm not 100% sure as to where everybody should be or what the normal is, but we're starting to take a look at that as well. And then the other option, or the other thing, rather, I should say, that we've talked about before is that, are you a tight surgeon or loose surgeon? I tend to put my knees in tight. And I also believe that it's important to try to balance it to the patient. So if I've done the right knee on a patient, we're doing the left knee, I always make it a habit of feeling the knee that we've done previously and really know, did the patient like that knee? Is that knee functioning well for them? Even if it was a knee that was done somewhere else years ago. Because if you have somebody that's tight and they like their knee, and you're between sizes. I mean, it's a really marginal sort of question of, I could go with this poly or that poly, and they like their other knee being a little on the tighter side. I more err on putting that knee in that individual a little tighter, whereas if a person has a loosey-goosey knee and they're really happy with it, and we're not talking leaving the knee loose in the operating room, but if I'm, again, between two sizes and I really could go with either A or B, I might use the poly that leaves that knee a slight bit looser than the tighter, because that's what that patient tends to like. I do see, not to kind of narrowly put people in categories, but younger guys, muscular individuals, active females, they all tend to like their knees in tighter. They're not happy with that loosey-goosey clicking or sense of instability. Whereas someone with other issues like pain syndromes and other problems, they're probably loosey-goosey to begin with. They have difficulty getting motion from a prior surgery. That's someone that I will not leave on the tighter side. And if I'm between two sizes, choosing the loose one. But again, like we talked about before, biology is a huge thing that we still do not understand, that you have some of these patients that they were perfect and they come back tight or loose, and they either stretched out or they laid down scar tissue. Now, when it comes to balancing, all this comes down to your soft tissue approach and your bony cuts, and then you're trialing, and then you're making this assessment of what do I need to do to, quote, balance, end quote, this knee, not knowing, again, what the patient is really going to like. So you're kind of doing all these things, and you believe at this point you're out of the woods. But I like you to remember there's really two more ways that you can screw up the balancing of this knee. And again, sometimes if you don't think about it, this is where you may make those mistakes and not recognize it. So most commonly, this is in older individuals with osteoporotic bone. So younger individual, if you're press fitting or cementing, you're wailing on this implant, it's not going to typically do anything to the bone unless you hit it like crazy and break something. But when we talk about older individuals, if they have soft bone and you put the implant on, you need to be aware of two things. One, that when you put the implant on the femur or the tibia, that you're putting it on parallel to the face of the cut. If you put your femur on and you're down on the lateral side and you don't recognize that and you wail on this thing and someone's telling you, oh, on the medial side, you're up, and you keep hitting it harder, it's already down on the lateral side. It's where you may compress the bone or cause a lateral condylar fracture. Same thing can happen on the tibia. So if you're putting the tibia on and you're down on one side and you don't recognize it and you're up on the other side and someone says, oh, you're up, and you keep hitting it, the side of the implant that's already in the bone is going to compress that soft bone. And again, now this can throw off your balancing. So I always make it a habit that when we put the femur or the tibia on is to make sure that it goes on parallel. And then making sure that you're parallel, then you can hit it equally straight down. But on a soft bone, do not hit it excessively hard. Again, you're cementing it. You don't have to wedge this thing in there. So even if you're off a little bit, when you put them into extension, you're going to get that little bit of compression at the very end. So it allows you to know that, okay, I am down. Now, that being said, so that's where you can screw up and cause an impaction of the bone or a fracture of the bone that can lead to laxity and poor balancing or poor alignment. Now, the other issue that you can use to your advantage, and I'm splitting hairs here. We're really getting down to the nitty gritty though, but let's just say you're off by, a quarter of a degree or a quarter of a millimeter. Going up or down or cutting it is just overkill. You do have the option at this point of, as you cement, if you just kind of tweak the knee and varus or valgus that quarter of a degree, or you don't compress it down as hard, you might get that quarter of a millimeter extra space that balances your extension gap just perfectly. You don't want to leave a huge cement mantle, which could cause issues down the road. But if we're talking about a quarter of a millimeter, a quarter of a degree, we're talking about fine little nuances that you might on purpose try to make the balancing as perfect as possible. But it is important too that if you were really at the smallest poly size and they were a little tight, you got to make sure this implant goes down. And this is one where you really want to lever on the foot and make sure that you're fully compressed in extension. Because if they were a little tight with the smallest poly and you put this implant in there and don't get the implant down, and then you let it harden, and now you're up a half a millimeter. Now you're super tight. Now you got a problem. So those little things can make a big difference. So we're not at the end of the case yet. We're going to get there. But just remember, if you're flying an airplane, the flight is not over when you touch the wheels down. The flight is over when that plane is parked in the or off the tarmac, at wherever you're going to dock, and the engines are off. That's when that flight's over. So there's lots of different ways where you can make a mistake throughout the case, but the balancing can still be affected all the way through the entire case. So those are two little caveats that you want to be aware of at the end in addition to the other stuff. So this is a whole lot of information. Again, we could talk for hours and hours and hours, but I just wanted to really make sure that I touched on all the points of the bone cuts, the soft tissue cuts, things that you can do to teach yourself the art of balancing and trying to know when it's tight, when it's loose, ways to watch out for osteophytes, things to do with the slope that can affect the minor nuances of balancing, and areas where you can make mistakes even at the end of the case when you're impacting and cementing. But hopefully this has got you thinking. So next time when you get back into the operating room, you can start to look for all these little nuances and try to come out with the best possible knee that you can give the patient who's put their faith in you. Again, thanks for listening. I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. If you've found this to be helpful, please subscribe so you'll be updated for future episodes. And if you like what you're hearing, please leave a review. This will help other people find this podcast. And if you have one friend or colleague that you think would enjoy and benefit from this information, please share this podcast with them. And until next time, this is Adam Rosen signing off. You've been listening to the Total Knee Tips and Pearls podcast. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.